afternoon, everyone. I will read the bio for Doug King. Welcome, Doug.
Hi.
Us today. Over 40 years of advisory and planning experience in healthcare sector, Doug King is an influencer in the healthcare facility arena, blending intensive involvement in design, planning of large-scale health facilities with research and involvement in academia. He frequently speaks at the healthcare conferences and in universities across U.S. on design for high-rise health facilities, and also his focus on implementing population healthcare design strategies, and most recently has been addressing the topic of artificial intelligence, which is the AI, using robotics on achieving logistics automation in healthcare facilities. He has also conducted different media interviews that have been noted, publications such as New York Times, Architizer, Design, Engineering News Record, and media throughout the provenance of cubic related to high-rise healthcare work conducted in that region. He has authored the only 2 published industry articles devoted to design and construction of high-rise buildings in healthcare facilities. Both are available on the CTBUH Journal archives. Additionally, Doug is active sharing through his leadership on different conferences, presentations, publication, and via social media. He's very active, by the way, on social media, which is, I appreciate that. While leading complex award-winning healthcare projects, Doug conducted IRB approval. He had funded research projects, and he had been appointed on different universities as a consultant or a lecturer. So he taught on Kansas University on the Health and Wellness Graduate Program. He taught in China also, and recently he's teaching on Northwestern University. He has lectured extensively, including at Illinois Institute of Technology, and the topics that he's covering all times, tall and super tall buildings program. So he focuses on high-rise buildings. He's on the interior design program also, taught on Drexel University and University of Central Oklahoma. He is published, a member of internationally based on tall buildings and urban habitats, and he had been elected as a member of Chicago Committee of High-Rise Buildings. He had also been awarded from the Healthcare Design magazine. He had been selected in 2021 as the top healthcare architect in the U.S., and in 2021 was appointed to the ULIS International-Based Healthcare Leadership Network. And he is international think tank of healthcare through leader from US, UK, and Singapore. So let's welcome Doug for his lecture. Welcome, Doug.
Thank you, Shireen. Thank you so much.
So please.
My microphone working?
Yeah, you don't need mine.
Both of them? Can you hear me back there? All right. Thank you, Shireen, for the tremendous introduction. The most important thing in the introduction I have that I want to impress today is the highlighted section. I have spent most of my career combining 3 things. Ironically, they're the 3 things that define an academic medical center. Now, you have several of them here in the broader Indianapolis area. The most notable one is at IU Health. Academic medical centers are the convergence. They conduct research, they provide teaching of health professionals, and they also provide tremendous clinical care. And so anytime you have those 3 elements together on a campus working collegially, you have what's defined an academic medical center. And about 20 years ago, I got the bright idea to say, okay, what if I made my career a personification of an academic medical center? What if I started to act in those 3 buckets or silos, in some manner, and started to combine those? And so I basically did that. I was afforded the opportunity to do that in my career. Worked with some relatively large companies, Perkins & Will, Stantec, who else here? Fluor, which is a big engineering group. I had a 4-year stint when I wanted to be an engineer to do power plants because I had bought a house and I needed to get a little extra money, you know, pay for the mortgage. And then one that went under, Hansel & Meyer, which at the time was the premier healthcare design firm in the world. So my career has been mostly large projects. When I was an intern, actually co-op student at the University of Detroit, my boss told me, he said, Doug, you have an affinity for big projects. So my career has been the Umakura University, which, by the way, Professor Granacki is familiar with. It was at the time the largest project in the world. It was actually put on hold to pay for the Gulf War. And then my power plant experience, I got an opportunity to renovate a nuclear plant that was sinking into the ground. And we converted it to a bunch of cogen facilities that powered Dow Chemical Company and most of Ontario and all of Michigan. And I was destined to get on this project team because when I went to the interview, the site plan was on the wall. And I grew up in a house right here. That's where my father sold our property just before they announced the nuclear plant. So I've got some history with a few things besides healthcare. I've lived in Dubai, worked there for a year, mostly doing hotel work. And then also in Chicago, we did the Spertus Museum. But most of my career has been in healthcare, and I worked for 16 continuous years on site with a couple of architects, but one in particular, an architecture firm called VOA, that we were in consortium with, at the time, Ellerbe Beckett, which is now AECOM and HOK, and then we did this, the largest private hospital in America. Today it'd be about $3 billion or $4 billion, sort of like the one you have downtown. I was the lead technical director. And then our reward for finishing on time and on budget, and we had to finish on time and on budget on May 1st, 1999, because our ribbon cutter was Hillary Clinton. And when the client told us that, we knew we had to get done on time. Our reward was we were handed the Prentice Women's Hospital. And we did that with the firm that's now called Canon, who you're going to be having some relations with in your organization. So the presentation I'm doing today, I've started around 10 years ago, 10 or 11 years ago. And I've had some help along the way. I've had a couple of collaborators. You're going to see some diagrams from a young man, Alex Taparis, who now works at Perkins & Will, but he worked with me at VOA. You're going to see the late Andrew Irvine. He was the head of urban places at Stantec. You're going to see some stuff he did on happy cities. And then you're going to see some work that Jingfen Guo, who is my research partner, did with me. Actually started this entire presentation with her assistants. She was my research advisor. So healthcare is personal. My goal for maintaining an interest in healthcare, my personal health, and my wife, Minnie, and son, Sherpat, can attest, is to continue to play sports. I'm pushing almost 70. I do play basketball. I do play baseball. I play baseball, Sherpat. And my main sport is table tennis. I like Marty Supreme. I hope you've seen the movie. And I try to play golf, but have failed miserably. I've went to school 3 times, flunking all 3 times. But it's personal, and I want to keep it, I want to keep going. My heroes are the 80-year-olds out there playing basketball or something. So I went to a conference. in 2016. It was the American College of Healthcare Architects. How many people here are familiar with the American College of Healthcare Architects? How many people are members? Okay, I knew the answer before I even asked the question. It's a wonderful organization. In 2016, they had a conference entirely on the subject of population health management. And that topic was chosen because around that time, they had changed the way that hospitals billed people. It used to be they billed them what was called the fee-for-service plan. you basically went to the hospital and then they sent a bill to the insurance company who then paid it. But about, I don't know, 10 or 15 years ago, somebody came up with the idea, you know, a lot of money is being wasted. Maybe we should turn the coin over and say, okay, let's focus our energies on keeping people well. Keeping them well so that maybe the cost will be less in the hospitals. So gentleman, Ken Kaiser, was one of the two presenters at this conference. We only had two presenters, and they both presented about this whole phenomenon. And so one of the big ideas that came out of this that forever has stayed with me is that approximately over 50% of the cost of healthcare is taken up with only about 5% of the population. 1 person in 20 is spending a bunch of money on healthcare, okay? In the middle here, we have a more, we'll call it equitable, you know, 20% or 15% of the population spending 20% of the dollars, and inversed here. And then we have a bunch of people, 1 in 33, who hardly spends anything, okay, on healthcare. Mostly younger people or people who can't afford healthcare. So population, okay, there's a question here. And I'm not going to give you the answer yet, but I want you to think about it for a minute. Who is the single most expensive patient that shows up at the emergency department? Hold that thought. Population health is about taking the people who are in the middle here, okay, the people in the middle here, their characteristics are they're probably not watching their health real well, okay, but they're living life large, and we're trying to keep them from coming over here. Because the characteristics of people in this column are people with multiple chronic illnesses, okay, and that's it. That could be, the minute you get diagnosed with like diabetes or something, you immediately start to fall into that category because other chronic illnesses come with it. And so what we're doing is we're trying to catch people early on and allow them to take care of their health so they don't move over to that column. And one of the measurements they use in public health that has struck me is life expectancy. This presentation, these slides, some of these are over 10 years old. And they predict, or actually precursor to the foci now on longevity. Longevity has become sort of a buzzword in healthcare. And for example, in the US, there's a significant range of how long people live. Somebody in Chatham, North Carolina, never been there, but I might move there, because you live to be at least 97, okay? Somebody in Stillwell, Oklahoma, where I have been, doesn't even make it to 60. Okay, and there's a huge difference in lifestyle and in what happens with your life. Now, what's interesting is they did a study called the Red Line Study in Chicago. They studied the life expectancy along the red line CTA line, a line that we live very closely to. We actually live right here. And so they discovered that there was a 30-plus year life expectancy difference between two neighborhoods that were literally 2 miles apart. Okay, 2 miles apart. People here lived only 60. People here lived to be at least 90. Okay, for various reasons. Very rich people live here. Very poor people live here. North Side's not shabby at 80 plus. I'm hoping it improves as long as I'm still there. What's interesting is you have the same issue in Indianapolis. Okay, in the Indy area, you've got people living in Carmel, up over 90. You're doing pretty well up there. And then people in the east side that are in their 60s. Okay, not as extreme as some other places, but still pretty extreme, which probably explains why the investment that's been made over the last decade or so in healthcare here in the state of Indiana has been a very smart move. Okay. Okay, so question. This one does have an answer. What are the 2 pieces of data that a public health researcher needs to know to determine your life expectancy? Anybody? 2 pieces of information. I pretty much just gave them to you, or one of them.
Zip code.
I'm sorry?
Zip code.
Zip code is a big one. The second one, your level of education. If they know your level of education and your zip code, they can predict with uncanny accuracy how long you will be expected to live. So that tells us a little bit about what today's presentation about is, okay, we can't necessarily change zip code, but we can work on environment, but we can certainly change things like education and job prospects, which bring access to health care. So some of you, many of you maybe have heard the term social determinants of health. This has gotten a lot of airtime. When I first started presenting this 10 years ago, this is sort of like a newer thing. And now, obviously, other people have this is a pretty common occurrence. And the big thing on this, big idea here, is that 20% of our healthcare is shaped by the quality of the clinical care. You could have the best hospitals in the world, and it may not matter that much if you got some other factors, like you got, situation where you're living unhealthy, drug smoking, whatever, and then you've got environmental factors. One of the things that came up, and I've never put a lot of that information into this presentation, but came up during COVID, was they discovered or uncovered the notion that one's location in a city, where you live, had a huge effect on how sick you got when you got COVID, or what the COVID rates were. And that lifted up a bigger issue of what is the contribution of, say, growing up in a community or in an area in a community that, say, was manufacturing or had other pollutants or had bad transportation or not any job opportunities. So the person's environment has become an increasing area of research in healthcare. So stepping back a minute, we'll look at what happens. And I mentioned that cost in healthcare, one of the reasons that the healthcare community, in particular Center for Medicare, Medicaid, and Housing and Human Development and stuff, at the government level decided to make changes was because 3%, 97% of the money, 90% of our dollars are spent after you get sick, okay? A whole bunch of money is being pumped into getting people well, a little bit of money into the ability to treat it in advance, not much. So basically what population health does, in addition to keeping people from moving into the multiple chronic condition world, they also are trying to move the dollars back to preventative care, to more to preventative care. So we've got this situation where we're trying to move dollars back to preventative care. We've got a situation where we identify that environment has an issue, et cetera. And so what I did was I attended this workshop in 2016, and I took down everything these people said. And I said, there's got to be a design component to this, or a planning or a programming component, because these individuals were not talking about that at all. They were talking about what was happening in front of us with this situation. So Jingfen and I got together and we said, okay, what do we need to do here? Okay, we need to provide a forum for betterment of individual care, i.e. a place that's conducive for that. We need to promote wellness. We need to proactively deal with impediments to seeking health care. And lastly, an area that popped up that people had been starting to talk about is treating staff well in healthcare so that they stay engaged. Because people who burn out that's not going to help us. So we turned to the sort of basic psychology thing, Maslow's hierarchy of needs. And that helped us sort of put a lens over where might we focus. Focus on access to food, housing, security, et cetera. And we began to look at this, and I said, well, maybe we need to come up with some strategies. And I used the word strategy. A light bulb went on in my head, our head, and basically we developed and brainstormed 16 ideas. 16 ideas that were a starting point. This is a starting point for looking at this situation. So these 16 strategies, and Jing Fen fortunately was better than me at doing pictures at the time, we began to come up with these sort of ethereal ideas, okay? Broad categories of things that we wanted to write about, speak about, research. We had grand plans. So I came up with another idea, because I'm usually involved in PR, and I'm also involved in fundraising. And I said, well, the company I work for, Stantec, has a very generous grant program. And so we applied for it and got I would say it's a semi-generous grant. Okay, it was pretty good, okay? And so we got a grant to study this topic. And my grand plan was to write a book. How many people in here know the book, A Pattern Language by Christopher Alexander? Okay, so my vision at the time was, let's do a pattern language type book for healthcare, for public health design. And so that's what we embarked upon doing. So we have pattern language, and by the way, those of you who are not familiar with it but are in the design world, it's a pretty good book to get a hold of and look at, because it's a great model for how to frame design aspirations. Christopher Alexander and his team were professors in Berkeley. They wrote a series of books in the early 70s on design. And so they wrote about how to, basically they wrote inspirational, aspirational books about topics, or chapters, shall we say. You might call them strategies. I said, why don't we look at doing that? So we started putting together some thoughts on these, and I'm going to go through them. They're not in any particular hierarchical order, but this is how we started thinking about this, and this is a living project. Okay, the first one that came to mind was because it was the one that struck us as being so, so obvious, okay, was the idea of housing. How many people in here know of a health system that has invested in housing? Yes. I'm going to talk about that in a minute. Okay, housing, there's several organizations. One that rose to the top about 10 years ago was one called ProMedica Health out of Toledo. They discovered that it was smarter for them to invest in developing housing, stable housing, education, health, job finances, all that stuff, than to just sit back and watch this stuff happen. Okay, then to deal with the outcomes of that. So they invested and became developers in Toledo, and a lot of other health systems have followed suit, and we're going to talk about some of them. The other thing that happened is there's a physician that is in the government who, I guess, they were able to figure out a way to prescribe houses for people who were homeless as medical interventions, because they discovered it was cheaper to buy somebody a house than to treat the medical conditions that came afterwards. Seattle, same thing. So I think that leads to another question here. So I attended a workshop. Our firm I worked for, I used to be a program manager. We did a rather large affordable housing project in Los Angeles in an area called Skid Row. Anybody here ever familiar with Skid Row? Okay, Skid Row was a predestined 1970s urban development where they basically took a bunch of individuals who were impoverished and homeless and said, you're going to live in this neighborhood. Okay, good luck. Have at it. And so that's what happened. And the neighborhood obviously has suffered greatly. And so we got involved in a project over that way to help individuals, and so did some other people. But part of that project, and not our project, but part of the research, they explored what is the return on investment? What is the return on investment for providing housing for someone who's homeless in terms of the healthcare savings? What do you think it is? 10%? 5%? Between $1.30 and $1.92 per dollar spent is what people are finding, and more, actually could be more. If you can provide housing for someone who's homeless and address their healthcare needs, you will reduce the healthcare burden significantly. Another driver for healthcare organizations to invest in housing. And there's our project in Skid Row. It's called the Weingart Center if you're interested. Another one is one that got involved in, which is urban farming. And I know that one of the faculty member here has a background in that, some others do. And that's a fascinating idea. But in healthcare, there are health systems who grow food on their campus and serve the food and provide the food, because there's a movement that came about in the last 10 years or so called food as medicine. Okay, food is medicine. And in Chicago, we have a particularly interesting case study on this. It's a wonderful organization called the Lawndale Christian Church Health System. How many people in the room here are familiar with, basically it's called FQHCs, Federally Qualified Healthcare Centers. By the way, you're going to get your master's in public health when you're done here. We'll hand them to you when you go out the door. But they are organizations that get an enhanced reimbursement for providing care to people who cannot afford care. I belong on the board of one called Tapestry 360. Our focus population, and I'm going to talk about them, is immigrants and refugees. I have a particular personal experience, close friends who are from Myanmar, who have come here under UN programs. And there's a very large Burmese population, as you know, in Indianapolis, Fort Wayne, and elsewhere, Chin in particular. And my friends lived in the Chin area, which had a civil war going on, and they were able to immigrate here. When people immigrate here as refugees, they don't have anything, okay? So Tapestry 360 steps in and provides that health care. But FQHCs in Lawndale Christian Church, remember that neighborhood where people only live to be 60 years of age? Well, that's where they're at. This stretch of Ogden Road was where the riots occurred in Chicago in the late 60s. And they have systematically rebuilt that corridor with healthcare initiatives. The Lawndale Christian Church. Think about that. They had they started the farm on Ogden. So I was inspired by that. I got a cold call from the ambassador from Grenada to the US one day. Somehow he got my name and called me up and said, we need a hospital, okay? And so I said, well, what do you got now? And he said, well, Fidel Castro gave us a hospital, but it's falling apart, it's 50 years old. So we designed a hospital for him. And in the process of doing the hospital, I asked, well, what do people grow in Grenada? He said, nutmeg and things you don't want to know about. So we said, how about if we take nutmeg as an example and we start to grow our own food? It turned out they imported a bunch of food within that island. This is an island country of about 140 to 150,000 people, which is interesting because I just finished doing a community hospital for a town about that size. So we designed a hospital that started out as basically a surgical center with like 20 beds. It grew to 100 beds, and then it grew to it actually grew to about 240 beds. Now you might say, well, why is it only one story? It's one story because they don't have anybody that can fix elevators. It takes 3 days if you get stuck in the elevator. And the only elevator on the island is in Parliament. Okay, so you do a lot of one-story buildings there. So, but I always thought this would be a pretty interesting student project. But this entire project was around the idea of celebrating growing your own food. And in Chicago, PMA, the firm I worked for, Project Manager Advisors at the time, we were program managers for a project that did just that. They taught people at the community grassroots level how to grow food. They taught them entrepreneurship. They taught basically skills in food service. And so these kinds of, this is not unique. There's probably one of these in most major cities. I could probably find one in Indianapolis in a few minutes on the internet. But these are the initiatives that have come up in this world. Now the next initiative is one I really like. Back up here as soon as I get to it. Because I attended one of the classes today, and one of the students, they were exploring, entering a competition, they were exploring the use of this project over a time of day. And one of the things that fascinated me about healthcare projects is that we would build these healthcare institutions, and they'd have conference rooms and such. And they only got used during the day. So I said, well, you know, one of the things about health facilities is they have space. They have incredibly knowledgeable and talented people at teaching skills that people need to know, and they even have some available time. So the Tapestry 360 facility I'm at, we have a conference room that's a boardroom. It does acupuncture, yoga, cooking classes, et cetera, et cetera. And this is not uncommon, okay? The idea that you can create spaces that use, particularly the evening hours, for community good is a huge benefit, huge benefit. Something to think about when we're designing projects, particularly projects that are like community centers. An example of one is it's in Idaho. It's a Native American First Nations facility, community center, that has a litany of community services. It's basically a fitness center combined with community center with lots of activities that benefit people and their health and their livelihood. Another strategy that popped up, I had a client who, Northwestern, and we had to build like 4,000 car parking garage for him. And the woman that was running that, Gina Weldy, the VP, senior VP there, said, you know, Doug, I wish that Uber and Lyft would figure this out so we wouldn't have to build all these parking garages. And so I did a little research, and it turns out that Lyft and Uber, how many people knew this? Lyft and Uber has a healthcare side that will basically, they tie in with your Medicare payments and provide transportation to people to get to appointments. There's a reason that when we set up an appointment, a health appointment at Tapestry 360 for my son, that they called me 5 times and said, you're going to be there, right? Because a missed appointment is a huge deal. It costs money, it costs time. And how to get there is an amazing impediment for people. Sometimes people have a really difficult time getting to an appointment. Things like this take care of that. Number 6, I worked on a flagship mental health facility for the VA in a beautiful area outside of Tampa. And so we had a project, in the building itself, we called it the centipede because it had a bunch of arms that came out, but it formed courtyards. And so one of the things we did was we programmed the courtyards in the facility to be part of the therapeutic care. There was courtyards for recreation, courtyards for gardening, courtyards for classes. We took advantage of the exterior extension of the building. Today, people do that with green roofs. We're going to show an example. But the idea that you can start to grow the healthcare clinical space beyond the walls of the hospital is an important thing. Along with that, another thing I learned working with the VA is that they embrace the healing arts. The VA, one of their core missions with veterans is to promote socialization. Socialization. So what they do is they create these programs using art and music to create that, camaraderie, which is important. And that happens a lot in the addictions world too. Addictions world, the idea of socialization, re-socialization is a path. And we can provide for that. This one actually is Jing Fen. She won a national IDEC competition. And her theory was you could take, as a single parent, if she went in the hospital with her son, who at the time was 5, what happens to her son? Because her relatives were in China, okay, or other places. What happens when you don't have a network and you're a single parent? So she did a project, a demonstration project, to show how to convert a patient room to a single parent focused patient room. It wasn't difficult, but it was something people hadn't thought about before. And it's something that I've not seen a lot of investment in, but it's an idea to think about. This also was one that we did a little bit of, got a little research on. Continuing on, I gave this talk in Austin, Texas, and I was talking to the cab driver. I said, well, I'm going to give a talk on hospitals. And he says, I hate hospitals. And I said, well, have you ever liked a hospital? And he said, well, the only hospital I ever liked was the one that had a library in it. He said they would come around with books, or you could go to the library, and it was a diversion for them. Obviously maybe before the internet, but the idea that you had diversionary activities for people while they're in the hospital was a big aha. And then another one we looked at is responding to how people behave in the hospital. The Northwestern Memorial Hospital in Streeterville in Chicago does not have a cafeteria. What we did 10 years ago was we got rid of the cafeteria. The cafeteria, we replaced it, and if anybody here calls it a food court, I'm gonna be very unhappy. It actually is along a pathway. It's along a pathway, and it's 14 retail food establishments that have been set up offering a range of healthy ethnic food and other alternatives that replace the cafeteria. And one of the things we looked at was, when doing it, was how do people work today? They work in a Starbucks or in a coffee shop environment. So we tried to replicate that within the hospital. And by the way, anybody know why there's no people in these pictures? Having people in them would be a HIPAA violation. And I had to go there at like 4:30 in the morning and walk around, and I found one person here. I have 2, I guess. But I walked there at lunch one day, and there were 1,200 people having lunch at one time. I had to count them so I could give this presentation, and 1,200 people, and they turn it over at least 3 times at lunch. And the other thing this does is by providing options for people who work at the hospital. If you have to go to the same cafeteria all the time, that's got to get old, okay? But if you got like 14 or 15 of these, that gives you some options. Number 11, I'm going to talk about this. Heartland Health used to be, they are what is now Tapestry 360. You are staring at the only LEED Platinum health facility in the city of Chicagoland, okay? It is a FQHC. It is almost all their patients get subsidized in some way, but we focused on having a beautiful facility. And so one of the things that the clinicians at this facility talked to me about when we started this was, one of the things that FQHCs, federally qualified healthcare centers, do not do frequently is they do not include, beyond healthcare, they don't include behavioral health and dental care. In fact, Tapestry sees themselves as unique because they provide all three. And it's super important, especially the growth these days of research that's happening in behavioral health. Unbelievable research, and Professor Karinsky, she is, at the top of the game on that, right, with the work that you're doing with autism. So, examples, in addition to Tapestry, there's another one. There's a bunch of these in Chicago. But there's one in particular that has actually been in the running for the World Architecture Award, and that is the Esperanza Health Facilities. Their designer is a guy named Juan Gabriel Moreno. Anybody here ever heard of Juan Gabriel Moreno? Okay, well, he's one of those people that is sort of like up and coming in the world of design. But his statement was, everybody deserves to get health care in a beautiful building. And these are in some of the toughest neighborhoods in Chicago. And they've revolutionized with some other people what a clinic should look like. What a clinic should look like when you go there. One of the strategies that got involved in, a lot of these happened about the time I was coming up with some of this. This one in particular, we won a national landscape design award. I purposely, by the way, put examples in here that touched on landscape design, urban planning, interior design, architect. Can anybody guess why I did that? Those are your majors here. Ball State is unique from the organizations that I have become familiar with teaching in the healthcare realm in the broad opportunities you offer for study. And this is an example of a landscape. We won a national landscape ASLA award. There was this couple, the Flaherty family, had triplets. And their triplets all were in the intensive care unit. Okay, they had 3 kids born, all of them very undersized. Children's Hospital in Illinois, Troy, basically saved their lives, okay? And on the 18th birthday of these kids, Mr. Flaherty presented the hospital with a check for a few $1 million and said, we'd like you to build something for the staff. And so we did something for the staff. It was respite care garden for the staff and for the families to go to when they're at the hospital. And so we did a modular, I have 2 instances where I should have patented something. One was this thing, okay? The other was, how many people here have ever seen a day bed in a hospital that folds out? We invented that. Unfortunately, on the Feinberg Alder Pavilion, we invented it. Unfortunately, KI Industries patented it, which made my boss very upset because his son is a patent attorney. Okay, and he was very mad at me. And so we did this modular park, mini park, that was lifted up 7 floors, and put into place piece by piece. Now, one of the reasons we had these was sun. The other reason was that the picture isn't in here, but about at the top of this roof as you go over are the 2 busiest helipads in the Midwest, because this hospital has a huge catchment area. And so we had to deal with the fallacy that everything was going to blow off the roof when the helicopter landed. I had a brave wind tunnel testing person from RWDI in Ontario who stood on the roof and measured the miles per hour. 5 miles an hour. 5 miles an hour under the helicopter. So we said, let's go for it. So another one, this is on a bigger scale. I just finished working on a project that's actually larger than your hospital in downtown Indianapolis. This one's 2.9 million square feet. It's the Peter Gilligan Mississauga Hospital. I was their high-rise consultant. I was very proud of myself. High-rise, and I also did all the, we did this entire hospital, we will move materials using robotics. We're using robotics. There are no sneaker power moving stuff through the building. And so I got involved in that aspect. But this one has lots of green roofs. We also looked at, on every floor, the staff lounge. You know the porch that you get in some hotels where you can go outside and shut the door and the HVAC, it cuts off when you open the door and comes back on? Well, we did one of those. Okay, we gave outside access in Toronto to staff, off the staff lounge, as part of the respite experience. 13, this is Heartland again. They developed a program early in their life. It won a national award. It's kind of fascinating. They actually developed a program where they put clinics in the elementary schools and in the high schools on the north side of Chicago, because their primary target of people, the patients, clients, is immigrants and refugees. And the first people in most immigrant and refugee families to learn to speak English are the kids. Okay, the kids become then the feeder for the family to get care. Because most families think they don't have money, they can't get care. Well, that's completely wrong. Okay, so they developed this ingenious program to do outreach by putting clinics in the schools. 14 is one I got involved in. I originally threw this in so we had a nice round 16. And I said, at that time, you know, emergency management has to come in somewhere here. Well, it turned out there were a couple things happened. There was a couple of hurricanes, okay, and the last building standing down in Hurricane Katrina was a VA facility, Biloxi, okay, and then Puerto Rico was obviously decimated with the hurricanes. And then I had the opportunity, of being the architect for, but do people here know what an alternative care facility is? Okay, in Chicago we have this convention center called McCormick Place. It's one of the largest ones in the world. It's got three halls. And so I got a call, and we teamed up with Walsh Construction, and we won a project to basically put 3,000 beds in the convention center, but we had to have it done. This was on like March 5th. We had to have it done in 6 weeks. 6 weeks to put 3,000 beds in. Beds is a loose term in this case. But we went ahead and did it. We did it. And we did it. We did all sorts of things. We worked on site. We had 2 shifts with 2 teams in case one got sick. We obviously at the time didn't really understand face masks very well. Most of us brought our ski masks to work. We worked together collegially with contractors, owners. Our client was FEMA, the Army Corps of Engineers, the city of Chicago, the state of Illinois. And so we worked and we used found product. We actually used scaffolding, construction HEPA filtering equipment, et cetera. We built this facility. We brought in trucks, okay, that were temporary bathrooms and the showers. And each of the 3 halls, each one had a semi-retired CEO from the hospital that was driving the completion of this. And in the case of this gentleman here was the former CEO of Resurrection Health System. And the energy, the stress, every day we're watching that curve. You may remember this. Every day the curve was going up. And we were trying to provide the spaces for people to, live in. So we did this project. And while we're doing it, my responsibility, amongst many, was to figure out how to keep it safe. How could this be compliant in some loose way with a code? So I got a hold of a guy named Doug Erickson. Anybody know Doug Erickson? I mean, yeah, he was the head of FGI. Okay, he also was, most code people, their name is Doug. My sub-expertise is codes, by the way. And so I called Doug and I said, Doug, what does the FGI guidelines or anything else have to say about temporary facilities or alternative care? He said, nothing. We have nothing. Okay. So as a result of this project, I got to help write the 4th volume here, which never got enacted. It's a 799-page tome on emergency response planning. As part of a team. We met every Friday and Saturday for months to put that together. And then I had a student, this is actually one of the subtopics of this presentation, is wanted to just touch briefly on I've leveraged in the past involvement with other schools in doing projects. And I had a student reach out to me, a capstone student, Minerva Zhang. She wanted to do an alternative care facility. She is from China. And anyway, she was at Rochester Institute of Technology. So I said, yes, we can, but you're going to have to do my project. So I gave her a project. I said, find any high school anywhere in America, and we're going to study converting it to a 50-bed temporary response facility. And she did. She found one in Red Wing, Minnesota. And the thing about high schools is they have libraries, cafeterias. They have larger spaces that can be converted. Okay, so we did that. And rather proud of her work. Real quick, last two. There's, I've gotten involved in some elder care work. This is another subplot from this talk, and this goes to students, and it deals with social media. Okay, one of the things I do is, or I've done, is basically I post blogs. I do blogs. My formula is a blog becomes an article. An article becomes a conference presentation. And if you do enough of them, you can write a pattern language book, or you can just write your own book. You know, and there's plenty of people in this room that have written books. So I wrote a blog that pontificated on the fact that the Gay Community Center in Chicago was basically the hospital of the future, because it had 15 of the 16 strategies that we talk about here in it. And so did a blog on that, much to the chagrin of the actual design firm, who to this day still is upset with me, you know. But hey, you guys didn't realize what you had. And so the issue we're having in elder care world is that we are creating loneliness. How many people are familiar with this idea of the acute loneliness that's occurring? And it's because we have technology. We now have, what do you call it? Telemedicine. We have people aging in place. There's not really a structure that allows for socialization amongst people who are older. For 3 years, I lived alone prior to my wife coming here from Thailand. And I can tell you that if I wasn't out, there weren't a lot of people around. You know, it's hard when you're living alone and if you're not real social. And so I've not had that problem too much, but the idea is that we're addressing loneliness here. And so we have to figure out a way to get around that, you know, to reinstitute socialization. And one of the things that the Center on Halstead did was they built two, it doesn't see in here, but there's two senior housing projects that are connected to this community center. Two of them, okay, to promote socialization and intergenerational interaction. And then lastly, super quick, there's a book, Sustainable Healthcare Architecture by Robin Gunther and Gail Vittori. I actually got to know Robin a little bit. It's a great book. How many people here have ever seen it? It is a great book. It's yay thick, been out a couple volumes. But they had a diagram in that book that, frankly, I stumbled upon that was almost the personification of what we're talking about here. This was a UN-sponsored design competition that they held, and this firm won the competition, and they created this project, Protea. Protea is a plant in South Africa. And they created this clinic that had all these various elements which looked suspiciously familiar to what I've been talking about. And so, and that was under the category of sustainability, which I thought was pretty interesting. It was a subject, there's several subjects I've been trying to avoid learning about because I've got enough going on, but this one is a great surprise. Then lastly, we're gonna go real quick here. One of the things I discovered is that, and I discovered this actually working with schools, a couple of universities, Kansas University being one, and some others, basically developing ideas through research and attempting to get the Center for Medicare and Medicaid Services to consider future, basically implementing these as cost-saving measures in healthcare. One we did was a Veterans Wellness Center. There is no place in this world, or in the United States, where veterans who have been in combat can actually come back and decompress other than in their own home or with friends. And so we're actually at Stantec, we're doing a demonstration project on this. And so I got students at Kansas, and we did one in Broughton, North Carolina. And one of their projects won the National Student Design Award, HCD, one year. It's an idea that is still waiting to happen. Another one we did was a year later. There's a really bad neighborhood in Chicago, rough neighborhood called Roseland, which is right near the other one that had people that only lived to be 60 years of age. Well, they were extending the Red Line, the famous Red Line, south. And so we did a project. I worked with the CTA, and we did a project. There's a hospital that went out of business near one of their new stations. And we said, well, what if we built a clinic or a hospital around the station? So that's what we did. We proposed the idea. And I'm going to go super quick through the case studies because I have like 1 minute left. But there's a couple of case studies here. Alex and I did a community hub that basically took these ideas and created a community. Let me very quickly show you. Yeah, basically created a series of clinics for a client in Florida that was not just the doctor's offices, but had some of these other functions. And then we also, my buddy Andrew Irvine, did a project with a guy named Charles Montgomery. Anybody here ever heard of Charles Montgomery? Okay, he wrote a book called Happy Cities, and had to do with the elements of what makes a happy city. And so he was actually consultant to my friend, and they replanned a community outside of Abu Dhabi. And so, and the big answer there was they developed the idea of the neighborhood as the sort of building block. And then lastly, we did a project about 20 years ago in Bogota. There's an organization called Copenzar, okay, it's sort of their social security group. And so we did this warehouse, you might call it warehouse for healthy living, about 20-some years ago. And it had all these features that I've been talking about. Designer on it, anybody here know a firm called Smith Gill? Smith Gill, Gordon Gill, and Adrian Smith designed the biggest building, tallest buildings in the world. Well, Gordon, in his youth, used to work at VOA with us. We did a series of, he's a very good designer, by the way, a series of these community clinics that basically fostered healthy living within the city of Bogota. And this was like 20-some years ago. So, you know, we're catching up. Last piece of information. Why this is all important is that hospitals are now, large hospitals are now taking on the flavor of urban design challenges. For example, in Detroit, Michigan, where I used to live and I went to school, they're building Henry Ford Hospital, like $1.5 billion, $2 billion. They're the ones who coined the term XL. I wish I would have coined the term XL when you're going to have a hospital over $1 billion. And so, but their project is interesting because they have a consortium of the hospital. They have they have Michigan State University funding the research component, and then the Detroit Pistons are funding the affordable housing element to it. So they've got the community, this community enhanced involvement in this neighborhood, which is called the New Center area in Detroit. So it's much more than a hospital. Another group doing that is the Mayo Clinic. How many people here are familiar with the 50-year master plan for the Mayo Clinic? They're going to turn Rochester, Minnesota into a destination for healthy living and for health care. The whole town, the reason you go there, the mission of that town is to do that. And so they have a couple of firms working on it. Canon's actually working on this, and they're working on this with Norman Foster. So what you're starting to see in healthcare is you're starting to see people like Norman Foster and Jeannie Gang and others get involved in healthcare. And then lastly, we have the hospital at IU Health here, which of course I've known about pretty much since the day it was announced. And you've got a new hospital, it's 800 and some beds, and it's got a new medical school. And what's coming out of that, I did a little bit of research, and they've got, you've got affordable housing initiatives coming, you've got commercial, there's probably other people here can talk about more about what the other collateral projects are. Because one of the things that happen when you build a larger hospital project is the collateral projects for the community that follow are actually quite astounding. And so waiting to see how this plays out. And so lastly, this is what population health is about, and that's how to get a hold of me. And thank you very much. I finished strong. Thank you. Questions? Questions? Comments?
Thank you, Doc. We'll open for questions. So anyone has any question to Doc? Great presentation, by the way.
Yeah.
I know you're focusing on urban, but how much do you think this translates to, say, critical access hospitals, which are kind of really undersold?
Because I grew up in kind of a rural area. I like that question because particularly some of the strategies and it gets into scale. For example, the idea of a building that actually can serve multiple functions. I kind of got aware of that because we used to have, I grew up in the country in like a township. We had to have a township hall. You'd get married in the township hall. You'd go to Boy Scouts or Girl Scouts at the township hall. You would, funerals might have an event at the township hall. And I was exactly thinking about the idea that that type of use comes into play in terms of the importance to community. So that the issue becomes one, I think, just of scale. Yeah, but you share if you have some other thoughts. Okay. Go for it.
You showed an interesting example, I think it's Seattle, of a hospital investing in housing. And
yeah.
A good return on the dollar. It would seem to me that housing is sort of in the realm of municipality, and the hospital budget would be a separate amount of money. How is that financing work? I mean, how is the return on investment coming from the hospital? Are they managing housing?
They are the developers. They're real estate arm. Some real estate arms, particularly larger hospitals, are fairly sophisticated. That's one approach, to be the developer. When we did Weingart, which is in LA, that was actually managing 6 different grants. There was a series of grants that came into play. And so that was an instance where, it was all grant money. And so, but hospitals have taken an interest in this because they are obviously playing defense. People are showing up unannounced in the EDs. People are coming in with tremendous health issues that the hospitals, by their mandate, are on for. They are on to cover that. Your question, though, brings up an interesting thing I overlooked, is actually when I talk about Andrew Irvine, one of the things that's interesting on the urban design front is we discovered that the initiatives that hospitals have to basically treat the community, keep the community well, keep people out of the hospital and save money are exactly the same initiatives that urban governments have for creating places to attract young professionals and others to come live. It's kind of an interesting parallel there. I know I answered your question with 2 answers, but thank you.
How many, thank you for the presentation, it was really an amazing one.
Thank you.
How many of these hospitals were being done by private entities?
Done by who?
How many hospitals of these has been done or constructed by private entities?
Being done by private entities?
Yeah, because it's most of the ideas that you have, it's really costly one. Yes, it has a lot of benefit to the society and the community, but it's really costly one. So how can we have a strategy to go for a private entity and try to persuade them to do such a project?
Now you bring up an interesting point, and I think I caught the gist of it. There are hospitals out there that are for-profit facilities, okay? And so the question becomes, and I can't, define that, but the ones that seem to be driven towards these type of thinking are frequently community hospitals. Community hospitals like the one I showed. In Chicago, the driver for this type of thinking is actually the Advocate Aurora system. They are tremendously invested in population health, but they're a community-based, facility. There's some others in Chicago. When you get to the private side, it's interesting because I tried to make a pitch to a very large academic medical center, not the one I work at, Northwestern, but another one, to look at these ideas. And they said, well, we don't really do this because we get enough money from the government already for our world-class health care that we provide, And I thought, what an interesting answer, They're in one of the most needy areas in the city and not really taking, ownership. One hospital, though, that is bridging that is Rush in Chicago. Rush is bridging, they're an academic medical center, but they behave more like a community hospital. And so I'll give them a lot of credit. So, does that help? All right. Cool.
Any other questions?
Questions from the upper deck? I've never had a I've done this, spoken in a lot of places, but I don't think I've ever spoken at a place where I had a theater up in the upper deck. That's pretty good. Yeah, well, thank you so much.
Thank you so much, Doug.
Thank you.
We want to say thank you so much. A great presentation.
Thank you.
It's our pleasure to have you.
2 quick things. It's available, okay? Presentation's available through
YouTube channel we have, and yeah.
and then second, it has been taped, right? Were you able to catch it?
Oh, yeah.
You hit the record button, right?
Yeah, I
okay,
think so,
good.
yeah.
And send me the link afterwards. I'll give you my card. I will be on social media. I'd love to have any and all of you reach out on LinkedIn. Okay, I use LinkedIn for presentations and for discourse. And I have my card here if anybody'd like a card. But please reach out. Thank you.
Thank you so much.
Thank you.